So next is common bile duct stones V9. A 50-year-old man has been admitted as an emergency under your care with a history of right upper quadrant tenderness and altered liver function test. How will you manage him? So again, first of all, I will review the history, including previous non-gallstones, any previous episode of cholecystitis, previous biliary surgery, drug, alcohol history, perform full clinical examination like general signs of dehydration, jaundice, sepsis, right upper quadrant tenderness, Murphy's, and Charcot's triad. That is abdominal pain, fever, and jaundice. And there is also Charcot pentad, including with conscious level and kidney failure. Review the blood test, white cells, amylase, CRP, liver function test, clotting profile, and urinalysis. Research the patient with IV fluids, IV fluid analgesia, broad spectrum antibiotics, and if there are signs of sepsis and cholangitis, arrange an urgent ultrasound scan to look for gallstones and related biliary tree. The ultrasound scan shows multiple small gallstones, a slightly dilated intrahepatic duct, and a 7 cm DVD. He is not septic. His LFT is returned to normal within the next 24 hours, and you suspect he has passed a CBD stone. What is your next management step? So again, there are two opinions here, and this depends on your expertise and what you had to do as a consultant. So discuss with the patient the two treatment options depending on the patient fitness for the surgery. So number one option is that we should do MRCP to confirm CBD stone is clear, and followed by laparoscopic cholecystectomy. And if MRCP shows stone, then we will see what he needs. And laparoscopic cholecystectomy and on-double cholangiogram or laparoscopic ultrasound scan. Proceeding to CBD exploration and stone extraction if necessary. So next question is, what are the risk factors for having CBD stones? Age more than 55%, bilirubin more than 30, and CBD dilation and ultrasound scan. There are 70% chances of the stones in the CBD, and less than 5% chances of having CBD stones at the time of surgery for a non-jaundice patient with normal diameter on ultrasound scan. So next question, if ultrasound scan shows multiple small gallstones and a stone in the CBD, how will your management change? So there are two options. One is that we should do ERCP to evaluate the CBD and remove the stone, put stent or sphincterotomy followed by left cholecystectomy. But ERCP will clear the duct of the stone, making surgery simple, but it's not without risk. Option, if patient is not fit for the lap cholecystectomy, then ERCP will be the definitive treatment. Then is the laparoscopic cholecystectomy and on-double cholangiogram or lap ultrasound scan, and proceeding to CBD exploration and stone extraction if necessary. So these all depend on the expertise and theatre equipment and complication of the bile duct leakage and tube displacement. So what are the advantages and disadvantages of these options? So pre-op ERCP ensures that CBD is clear of the stone prior to surgery, but it has complications including a small mortality risk. Laparoscopic CBD exploration requires surgical expertise and surgical equipment. There is no evidence difference in the efficacy, morbidity, or mortality when the ERCP is compared to the lap CBD exploration, but surgery has a shorter stay because the patient is treated in one admission. How would you perform a lap CBD exploration? So there are two approaches, transcystic or direct supraduodenal CBD exploration. So transcystic, we have a limitation. It's only for the small stones than 7 millimeters, fewer than 3 stones, and only can remove the stones below the insertion of cystic duct, as it cannot retroflect the scope into the common hepatic duct. And now the second option is direct supraduodenal CBD exploration. Large stones and multiple stones avoid if small caliber CBD due to the risk of biliary stricture. Usually lap CBD exploration is reserved for the CBD diameter of 8 millimeter. A longitudinal choledochotomy is made with the hooked scissors, avoiding the bile duct arteries at 3 and 7 o'clock. Stones are extracted via the endoscope of the basket. Completion cholangiogram is performed and choledochotomy is closed. T-tube insertion and primary repair without T-tube stent, both are acceptable. If T-tube is inserted, go for the T-tube cholangiogram for 7 days. Tube is clamped if it is clear and there is free flow into the duodenum without any filling defects. Remove the tube in OPD in 6 weeks time. Finish.